Good afternoon, everybody. My name's Terry Hudson. I'm the clinical chair of Sheffield CCG. I'd like to welcome all of the members to this month's September governing body meeting in public. Welcome members of the public that are watching us on our live stream on YouTube. So onto the agenda, we've had apologies from Leslie Smith and from Nikki Normington. And no further apologies for absence received at this stage.
Chair, could I just say John McElraith gives us apologies, and I've come for John today.
Okay, thank you very much, John. So we'll note those apologies. I can confirm that the meeting is quorate and is able to go ahead. So we'll move on to item 2 of the agenda, which is declarations of interest. So just invite members of governing body with a declaration of interest to make that known now. So Mandy Forrest.
Sorry, item 3, table 3, mentions discharge planning grants to the voluntary sector in the Carers Centre, which I am chair of. So I'd like to declare that interest, but in the item, I'd like to clarify the issue. Thank you.
Okay, right, thank you, Mandy.
And if we can, if we can just record that there's no decision that's been asked for in that report, it's just for noting.
Yeah, and we will go into the detail of the clarification of what's needed when that item comes up onto the agenda. Any further declarations of interest from any other members in any of today's items? Okay, so no further items being declared there. So we'll move on to item 3, which is questions from members of the public. As of about 10 to 2, there were no questions that had come in from the public. Jackie, have we any change on that position?
No, that's the same.
Okay, so no items coming in from members of the public there. So opening remarks has been 4 weeks since our last governing body. Much of the work of the CCG has been concentrating on the restoration of clinical services in light of COVID. We've got some items coming up on the agenda this afternoon, particularly around planning for phase 3 and some of our commissioning intentions. And I won't go into detail on those now, as they're going to be a substantive item on today's agenda. So I will move us on to item 5, approval of the previous minutes. So that's paper A in the noting pack. And what we will do is we will take the minutes page by page if we can. And if members of governing body could alert me to any inaccuracies or amendments as we go along, that would be particularly helpful. So we'll take pages 1 and 2, 3 and 4, 5 and 6, 7 and 8, 9 and 10, 11. Sorry, Mandy.
Hi, could I just check the minute as it reads on page 9, which was the action around the sponsorship, and then there's a sentence with the post-meeting note on it. I don't understand the minute on the post-meeting note, because it doesn't seem to be any different than what we agreed in the meeting.
I think, Mandy, there was a request for some clarification as to whether governing body had declined the offer for sponsorship or whether governing body were unable to reach a consensus to accept that. So the post-meeting note there is to clarify that we couldn't reach a consensus, and that was the reason we couldn't approve the sponsorship, as opposed to there was one specific point the governing body was refusing the sponsorship on. It does bring into, not bring into question, but it does bring a question to governing body about the ethical frameworks through which we might look at future sponsorship proposals. and that's something that we propose to pick up in a governing body development session.
Okay, well, thanks for clarifying that. So I'm not querying the minute now. Thank you.
Okay, thank you. Does anybody else have anything they wish to say on that part? Okay, so I have forgotten which page we got to, so we'll go from page 11 and 12, please. 13 and 14. 15 and 16. 17 and 18. Okay, so we will approve the minutes as they are, as an accurate record of August's governing body in public. So I'll move us on to our next item, which is matters arising and follow up on reflections. So in terms of the reflections, there were lots of thoughts and lots of comments, but we haven't got any specific actions from those at this stage. And hopefully we will be able to take those into our development session. So for today's meeting, I'm going to propose that we don't follow up on those reflections, but that we do that in more depth at a later stage. Judy Robinson, hand up there.
I just wanted to pick up two things which are not noted as matters arising. Under 9820, the assurance framework, I asked a question about how we were going to make some major engagement about changes to services, but at a rapid speed. And there's a question about whether those two things were possibly in. Going to be some further discussion, I think Jackie said. I just wonder when that was going to be. That was one thing. And then the other one was on 100/20 about CHC. And I made a comment about that and asked about communication to people who have been in care homes. And I want to pick up on that as well.
Okay, so if it's okay with you, Judy, what we'll do is we'll go through the matters arising item by item. And as we get to those bits, hopefully we'll be able to clarify some of the questions you've got or give an update on where progress is to date on those. So we'll move us straight in then to the matters arising table, which is paper B in your noting pack. So item 122.19. Which was around a public question about workforce and the situation of workforce across both the ICS and our ACP workforce group. We did receive an update on that towards the end of August, and I'm wondering if I can hand over to you, Brian, just to give us a verbal update on where we are.
Yeah, so now that we're starting to relook at sort of normal business, that information is now being played out through both the ACP and the ICS work stream. So we will update and take the product from that in terms of a workforce report to a future governing body, but the work still continues.
Okay, thank you. So next item on our matters arising, item 1320. This is around our performance, quality and outcome report. Specifically, there were 2 points. One of them was around gathering data and intelligence from practice, particularly with relation to Yorkshire Ambulance Service. We did have some information submitted to us in May. Brian, this item's still open. Are you able to give us an update on whether that item needs to remain open or whether it can be closed?
It needs to remain open because the information still hasn't been presented, but is now starting to be gathered. So we will be able to report at a future governing body, Chair.
Okay, and does that include the second part of that item, or do we need to go into further detail?
No,
so, okay, that would be brought back to our next governing body meeting. Item 3620 is around our operational plan, including the commissioning intentions. That's being brought today as a substantive item on the agenda. Is there anything additional to that, Brian, that we need to discuss separate from the item that we will be looking at in detail this afternoon?
No, I think it'll be covered as on the item, Chair.
Okay, thank you. Item 7820, feedback from lay members and discussion with the chair of Health Watch. And there was an item there from Mark Gamsu that we were going to get an update to August governing body, and also that papers have been shared. The item's been recommended for closure, and in the absence of Mark, we will not be able to get a verbal update on that, but we can circulate some clarity of that with the post-meeting minutes, if that is okay with everybody today. Okay, thank you. 8320, around seeking clarity for the routes of dentistry support in care homes. That's recommended for closure, but given it was a sort of a contentious item in a previous meeting, Alan, are you able to just give us a quick update on the position there?
Yes, I think the original question, Chair, was with regards to support on dentistry to care homes through the COVID period. Like the majority of population, access to dentistry was reduced unless it was urgent. Care homes across Sheffield are signed up to the residential oral care Sheffield service, so received continued support through them. Where a home doesn't have or engage with that service, they have other services that they engage with. So every home is covered, and dentistry continued for emergency care through that period.
Okay, thank you. So we're happy that that item is now closed. On to item 8420, two parts to this one. The first one was around access to midwifery staff in general practice premises. That item's still open. I'm wondering if you could give us an update on that, please, Alan.
Again, the midwifery one was relating to some practices that was fed back to governing body that weren't allowing midwifery services in. On investigation, there's an update in the patient safety and quality report on the agenda for that on the item, Chair. But on investigation, it appeared to be one practice or two, very small numbers, but other services were allocated to those individuals, and it was due to the risk of access into the GP practice. We've received assurance back currently that all the services have been maintained, although they're in different areas due to some of the satellite GP practices not being open. And it's anticipated that full recovery will be in place by November, December this year.
Okay, thank you. The second part of that item was around looking at oversight of safeguarding board performance reports, and that's been recommended for closure as the safeguarding performance report is going to be included in the next governing body quality and performance update. So that one's recommended for closure. Item 9620, the Deputy Director for Communications is going to pass governing body thanks on to Faith Star. That has been completed. 9820, governing body refresh. Jackie, are you able just to give us a quick verbal update on the closure of this item?
Yeah, so I did contact my fellow CFOs in the South Yorkshire CCGs, and they all confirmed that they either had already rated a similar risk as extremely high or were intending to. Okay,
thank you. Item 9920 around the sponsorship proposal and the post-meeting note. Mandy has brought that up earlier, and we've discussed that, so that item is now for closure. Item 120. Sorry, Jackie.
Sorry, that item's going to remain open till we clarify our position in terms of sponsorship.
Okay, thank you. So we'll leave that open, and that's a more general item about sponsorship proposals broadly, as opposed to that specific proposal that was brought forward. So just making sure we're clear on that one. So Carol, are you able just to amend the confirmation of actions and actions still to be taken that this item's in relation to all sponsorship proposals over 5,000, rather than just this specific case with AstraZeneca. Okay, item 100/20. There were two parts here around access to swabbing for staff in the voluntary sector. I understand that we're still waiting for an update on the requested information. And then the second point on this part here was around, Lucy, you were going to pick up some points raised in the discussion with governing body members outside the meeting, and there's an update to be given today. So are you happy to give us an update on that?
No, sorry, I was going to email governing body members, but I totally forgot to do it. So I'll do it today because we've got the list of questions, but that's okay. Okay,
thank you. Item 101/20. This was equality impacts of COVID and the mitigations. So again, Lucy, that work's been completed. Are you able to give us a very brief oral update on why we're recommending that for closure now?
I emailed Judy. She did respond back with a couple of questions, and I did follow it up. So as long as Judy's happy with my response, I can't see Judy.
So Judy, just unmute yourself and say that again for us.
Sorry. Yeah, we were having a correspondence over the last 10 days. So I will come back to Lucy if there's further questions.
Okay.
You did raise some important points about us working more closely with Healthwatch, but we're on track to do that. Okay, thank you. And then the final matter arising is our month 3 finance report. The request at last month's governing body was for Jackie to perhaps look at arranging a masterclass, particularly looking at how we can work creatively and innovatively with our finances, given the financial arrangements that we have at the moment post-COVID. So I'm imagining that we won't have been able to organise that in that short period of time. But Jackie, are you able to give us a quick update on progress to date?
Yeah, I think the difficulty with this one is that the information's still changing rapidly at speed. So it's quite difficult to give a masterclass when the facts are rapidly changing.
Okay, and just for members of governing body, whilst there's not clarity on what the financial situation is going to be, there is some explanation of that in the finance paper a little bit later on, and hopefully we will receive an update on where we anticipate things may be moving forward. So Jackie, your hand's back up. I'm guessing you want to add.
Not to that particular point, just picking up Judy's points on the minutes. There's a couple of matters arising that haven't been noted. So if I just pick these up for the record.
Okay, thank you.
Okay, so under 97/20, there was a specific action around asking members of governing body to sign the conflict of interest declaration, which I haven't yet actioned, but I will do so. So just to note that that's an outstanding action. Judy's just asked for clarification about the point she raised under that item, which was around how we engage the public more in those decisions. The reference in the minute was to note that Lucy was covering that under the item that she presented around reviewing our decisions and how we bring back decisions that last for a period of more than 6 months, how we were going to engage people. So that was what I meant in the minutes, Judy. I'm just clarifying whether you were expecting further action apart from that.
I wasn't sure what the action was meant to be, but that's helpful to clarify. I think it was a point about if we want to engage people around major changes, we need to give time to do that.
Yes, yeah, and I think that's a fair point. And the last note that Judy just mentioned was under item 100 and /20, which was around the CHC correspondence. And I don't know, Alan, whether there's any update around CHC and letters to patients impacted, or whether we need to take that offline.
Apologies. I've unmuted. It may be picked up in the patient report later on, because I'm giving some additional key points around continuing healthcare and the engagement and communication that we're undertaking with all applicable residents of Sheffield. So if Judy feels there's an additional question at that point, it may clarify some of the question, but any additional questions that arise can be picked up at that point. Is that okay?
Which item was that, Alan? Under which item?
Under patient safety and quality report.
Okay.
Of continuing healthcare in the full report, and I was going to give some key developments that have happened and how we're engaging both in 3 sets of continuing healthcare groups that we have, Judy. So I may some of my answer may pick up on the question that was raised. If it doesn't, we can pick up at that point any additional questions that you may have. Is that helpful? Would that be helpful?
That's very helpful. Yes, thank you, Alan.
Okay, thank you. So any other points members wish to raise regarding the matters arising? Okay, thank you. So we'll now move on to item 7, which is our patient story. So I'm going to hand over to Alan Windle to introduce the story for us.
Thank you, Chair, and thank you to Lucy and her team who've pulled together a case study for us today relating to a Sheffield patient. I'm going to call, a Sheffield resident. I'll call this resident Mrs. J, if that's okay, as it is an anonymous. The patient story today centres around Mrs. J, and it's told by workers from Terminus Initiative, a charity working in Low Edges, Batemore and Jordan Thorpe. Obviously in some of our most deprived areas in Sheffield City. The Terminus Initiative has been supporting Mrs. J for many years. She is white British, in her 50s and lives alone. She suffers from a number of long-term conditions, also migraines, and also suffers from depression. She takes lots of medications for various illnesses and has regular hospital appointments. Unfortunately, in the last year, she's experienced several bereavements also, including significant deaths of her parents and a long-term partner. Her history is that she's engaged in the community, volunteered in charity shops, and attends art groups and carers groups pre-COVID lockdown. Just before the pandemic started, the Terminus Initiative encouraged Mrs. J to receive help from the Ripple Bereavement Project, which is run by Age Better in Sheffield and Sheffield Mind. This was a big step for Mrs. J, as she had mental health problems in the past and suffers from depression sporadically. This was the first time that she'd agreed to accept any form of counselling or therapy. Unfortunately, after just 1 or 2 sessions of therapy, the Ripple service and the Terminus Initiative both had to stop face-to-face working due to the pandemic and lockdown. Mrs. J received also a shielding letter due to her health conditions. So in addition, had also been isolating at home. The isolation caused by lockdown had been extremely difficult. She had opened the floodgates about her grief and other mental health problems just before the lockdown. And as she opened up to these groups, which was difficult for her, we went into lockdown. So actually, she was then very much isolated. Mrs. J deals with her emotions by keeping busy. The groups run by Terminus provide solace where she can relax, arts and crafts. She saw friends, had some social interaction. She'd been trying to keep her mind off things by gardening, decorating the house. Because of the poor health, this results in her feeling tired and unwell. And obviously the impact of COVID on lockdown has made those tasks even more difficult due to her feelings. the initiatives that were initiated, unfortunately, didn't offer that solace that she had previously, pre to lockdown. She continues to receive phone calls from Terminus and Ripple projects. She's not always up to feel up to talking, and at times she does have ideology of suicidal thoughts. She feels she cannot share her feelings with her sons, as it's her job to be their support. On one occasion, Mrs. J, incredibly upset about an incident had experienced over the phone with a receptionist at a doctor's surgery. Because of the close links with the health team, Terminus have with the local doctor's surgery, they were able to contact the surgery and the pharmacy on Mrs. J's behalf to help with the problem. And after a period of time, this was sorted with a direct conversation with the pharmacist. The whole incident, on top of the stress of shielding Mrs. J's mental health, and to it's at an all-time low. At her lowest, she mentioned not wanting to be here anymore. This was put in a safeguarding report, and again, because we have known Mrs. J, this is the Terminus group, for many years, we know how she was capable of actually improving home mental health through the activities with encouragement. It's going to take very careful handling through these groups to continue to support Mrs. J through the Terminus initiative and the NHS collectively together, but it will be one step at a time for this lady. The story itself shows the impact COVID has had on one person and how lockdown has exacerbated her existing both physical and mental health needs. The role of the third sector in helping and supporting people through it can reduce the impact on secondary care, both physical and mental. We know more people in Sheffield face the same challenges as Mrs. J, and also who have also deteriorated through the pandemic period. I wanted to present this as I hope it helps guide our planning discussion throughout our governing body agenda moving forward, as hearing these kind of stories should be the focus of how we plan for future services to support in the community and prevention of exacerbating both physical and mental health problems. From a governing body perspective, I would like to feed back to both the agencies and to the individuals' bravery in presenting their story to governing body. You know, it's a big step for this individual to have opened up as they have, which allows us to be able to reflect on any planning that we have in the future. So I would like to extend governing body's thanks back to both the services and the individual.
Okay. Thank you, Alan. The story is a really poignant reminder that coronavirus is not simply a virus that affects people's lungs and causes a physical condition, that actually, the impact on services, the impact on people's ability to do the things that keep them physically and mentally well has been severely impacted. I think we will all be in agreement in sending our thanks as a governing body back to Mrs. J and also to those agencies involved. I just want to open it up to governing body for any reflections. So I can see Chris Neal, you've got your hand up. So if anybody else has any reflections or any thoughts on this story, I think it would be a good time to hear those now. So over to Chris, please.
Yeah, to thank Mrs. J for sharing her story, but I think it does have some lessons for our planning and also previous work, because having that partnership between the services, the Terminus and the CHC services, the Terminus, and also the GP practice, meant that the Terminus were on the ground, and it would have been difficult for the other agencies to pick those issues up. through shielding and COVID. And also the existing partnership and trust meant they could start to take some action, but shows how vital that partnership arrangement is, and that localised response can make a big difference. Otherwise, some of those issues could be invisible. So thanks again. I think there is some significant learning of good practice and how we can perhaps build on that. I know this isn't sorted, but at least it's been identified, and hopefully the support will be there to improve the situation.
Thank you, Chris. Mandy Forrest, please.
Thanks. Thanks for that, Alan. And like everybody, thanks to Mrs. J for sharing her story. It feels particularly timely to have done so because yesterday the lay members and Brian met with Voluntary Action Sheffield to talk about how we can reset as a city our relationship with the voluntary community and faith sector, recognising the huge amount of work that's been done to support citizens in the pandemic, far beyond the bit around infection, but actually, just supporting people to cope with the impact of COVID, the impact on food poverty, social isolation, and links into the community. And we talked about how flexible and responsive mutual aid groups have been, how they've been supported by community anchor groups, by community hubs, and made a massive, massive difference in the city to the experience people have been through. So it's amazingly timely that that story was brought, and I hope we hold on to it when we're talking about how we want to work in the future. We agreed as a group yesterday that we really do need to do things quite differently. Brian, I don't know if you want to just to add, because you were in the meeting as well.
So, Terry, I think, Chair, my hand was up to follow on, and Mandy, I was going to say, well, not exactly what you've said, but it is incredibly timely that the story that we heard today is the conversation that we heard yesterday. And I know the conversation that we're about to have around planning and our priorities, where we rightly, as a governing body, focus on our responsibility around health inequalities. I think this brings into reality as well the role that the voluntary community and faith sector have shown through both this pandemic. And I'm minded to sort of then relate that back to the State of Sheffield report that was launched last week, publicly, of which Greg was there, myself and Mark. And again, sort of that strong voice about what do we as a system and we as a governing body and organisation, what do we need to do and what can we do to have a sector that can both survive, because a number of them are already, if not close to the edge, on the edge or falling over it, but also create a thriving voluntary sector. So I think our commission and responsibility and our commission and response needs to keep that at the forefront of what we do and how we act. So thank you, Mandy.
Thank you, Brian. Judy, please.
Yeah, I very much support what people have said. For me, those stories have a message about strategic partnerships and how commissioning processes involve people and listen to people at the design and the management and the evaluation stages. So we don't just look at those ticking boxes, if you like, but at those experiences and how that shapes commissioning. Because otherwise the stories are great, but there are lots and lots of them. It doesn't actually alter the way we run things. And that seems to me to be the biggest lesson from all of this.
Thank you, Judy. So, Alan, as previously mentioned, if you would pass on our thanks to everybody involved in that story, I think governing body will be grateful for that. And as always, we will continue to hear real life stories in future governing bodies, which helps us really to focus on what it is we are here to do. So thank you for bringing that, Alan. I'm now going to move us on to item 8, which is planning for 2020/2021. And some of the points that we've just raised will be quite poignant to this part of the discussion. So I'm going to hand over to Sandy Buchan, our Director of Commissioning and Performance. She's going to give us a presentation on the planning and CCG commissioning intentions for the year ahead.
Thank you, Chair. I've also asked Lucy to help with some of the presentation parts of it as well. So me and Lucy will be doing a double act in presenting these slides. So this presentation is to update governing body on the progress that has been made to date on the planning requirements. But also what I'd like to say is, after hearing that patient story, hopefully throughout this presentation you will also see how feedback from the public and engagement is being used in order to inform what we do and how we do it. So hopefully by the end of the presentation that will have come through as well. And like you said, Chair, it's very poignant that that story was presented to governing body today. So the progress to date, if you could go to the next slide, please, Lucy. The progress to date. So the organisational challenges have been reviewed and confirmed as fit for purpose. There's been a lot of work happening, especially with led by the deputy directors, to ensure that the challenges and the commissioning principles, along with our vision and objectives that were approved prior to COVID, still remain fit for purpose and relevant to go moving forwards. So there's been some suggested amendments around the commissioning principles wording, which still need to be finalised, but the basis of those have been approved by the governing body. Following from that, teams have identified the commissioning implications arising from COVID and its consequences, and that's very much been a part of the review of our commissioning intentions going forward, to make sure that we are picking up everything that we've learnt and has had an impact during the COVID period. As a result, our prioritisation criteria to identify what those intentions are going to be have been reviewed, and we've included a greater weighting on reducing health inequalities. We've therefore reviewed the commissioning intentions for 2021, and we're currently in the stage of finalising them, which I'll come through later on in the presentation. We've also had discussions across the health and care system in Sheffield. So just go back, not only to ensure we meet the requirements of the phase 3 letter, but also to address the inequalities across Sheffield and making sure we address those needs. And also at an ICS level to make sure that we're involved in the larger programmes of work across South Yorkshire and Bassetlaw. And finally, in terms of the progress to date, the first draft of the planning submission that we've been required to do in terms of our activity and restoring those services back to pre-COVID levels has also been submitted. So I just put these up on the slide just to remind the governing body in terms of our vision. Our objectives remain the same and remain fit for purpose. The next slide just identifies the challenges and the principles. And again, like I've said, the principles, there's still some tweaks in terms of the wording, however much the basis is in line to what we want it to be. In terms of the phase 3 letter, on 31st of July, NHSE and I wrote to NHS organisations to outline the third phase of the response to COVID and the NHS's priorities. The focus for this phase is on restoring, recovering services and preparing for winter. So therefore the priorities very much are those accelerating return to non-COVID health services, and each of those areas have a suite of requirements and indicators and will be monitored throughout, and they've very much been weaved into our commission intentions so that we ensure we are meeting what is required from us through that phase 3 response. Preparation for winter alongside a possible second wave of COVID, very much working with our partners across Sheffield to ensure the appropriate infrastructures in place, supporting our workforce and aligning that with the NHS people plan, and action on inequalities and prevention. So in order for us to achieve those requirements, all organisations across Sheffield have agreed that we need to be aligned and work together very much as what was demonstrated throughout the COVID period. And what we've done as an accountable care partnership is come up with a set of principles that have been developed to support that integrated working and how we approach the requirements of those phase 3 letters together as a system rather than as individual separate organisations. And these were developed and agreed by the relevant organisations to really make sure that we can work together and not cause a negative impact on organisations when we look at what it is we need to do moving forwards. So I just wanted to put this to governing body to show that all of the organisations across Sheffield are working together in order to deliver the requirements as set out within the phase 3 letter. So, as I've said, the deputy directors within the commissioning portfolios within the CCG have been working hard to look at pulling together our commissioning intentions, and they have been drawn up in response to those phase 3 requirements, as well as ensuring alignment to our partner organisations across the ACP. What I'm presenting today are the draft overarching priority areas rather than the individual commissioning intentions. These are being finalised, and what I want to do is bring back to governing body within the full operational plan of how we're going to deliver them, achieve the requirements that are set out, identify the key outputs and outcomes, but which all of these are being finalised as part of that planning submission process, ensuring that we are aligned to not only to the requirements that we've been given through the phase 3, but also in agreement with our providers and organisations across Sheffield. So these are the overarching areas within the specific portfolios within the CCG, and it just gives you that overview of what the specifics of what we're looking at. As you'll see as you look through them, so we've put each of them in different areas, but as you'll see, there are some crossover themes, and within the commissioning directorate now holds all of the portfolios together, and we are looking at how we work across the portfolios, not just within the specific areas, to ensure that we have the capacity and the skills in order to work not just within the areas that you see on here, but very much across. So, for example, the care homes spans across a number of these portfolios, as well as winter resilience, etc. So, those particular areas we are looking at how we can work up the capacity within the CCG that does filter across. So, looking at all age, not just children and adults, and looking at mental and physical health together. So really utilising what we have within the CCG to make sure that we can deliver what these intentions set out to do. So if we go on to the next slide, the phase 3 requirement specifically focuses on an ICS level plan. And whereas we are developing our local Sheffield plan to, the local planning feeds into that South Yorkshire and Bassetlaw system. So what I wanted to show governing body is that we're very much involved in those higher level programmes that span across all of the places across South Yorkshire and Bassetlaw. And as you can see, the plan itself mirrors what I've just talked about in terms of the 3 priority areas within the phase 3 requirement letter. And within each of these areas, we are very much a part of developing that and ensuring that our local plan is embedded within it and working with the ICS. So making sure that on all of the levels that I've discussed throughout this presentation, that we have that strong influence and involvement in terms of what we're doing within Sheffield. One of the main things within the phase 3 requirements is on health inequalities, and I'll just ask if Lucy can pick this next few slides up.
Thanks, Andy. So within the phase 3 letter, there are 8 urgent actions to reduce health inequalities. I'll just quickly read through them. So protect the most vulnerable, restore NHS services inclusively, have digital services but that are inclusive, accelerate preventative programmes of work, support people with mental health problems, for each NHS organisation to have a named exec board member, for health inequalities and boards to publish a 5-year action plan. And there's a big focus on data, so ensuring complete data sets, and also collaborating on planning and engaging with our communities. So just a bit of an overview of what we're doing around health inequalities and particularly around to inform the phase 3 plan. Hope you'll all appreciate that health inequalities has always been high on our agenda, and actually it's the first of our 5 organisational objectives. As Sandy mentioned, when we reviewed our commission intentions a few weeks ago, we looked at the prioritisation criteria and we placed a greater weight on reducing health inequalities than compared to when we went through the process in February. We've set up a new inequalities group or equality group in the CCG. It's quite a new group. It was organically formed, but we're looking at influencing the organisation and with the work we do outside, so our staff and commissioning focused. We're also part of the ACP Strategic BAMA group, which is chaired by Clive Clark. And our first piece of work, which went to ACP last week, is an action plan. We've agreed some priorities around racial inequalities, and these will address data, leadership, staffing, commissioning, comms and engagement, and they'll meet the requirements of phase 3, the Fenton report, which is beyond the data, and the NHS people plan actions. The Health and Wellbeing Board has also commissioned rapid impact assessments. They're being published imminently, and they cover topics such as bereavement, poverty, end of life care, mental health, alcohol, and the CCG have been actively involved in those. And as part of our population health management approach, we're using data analytics and patient engagement to target our post-COVID support, which includes social prescribing. So the next couple of slides, which I know you've been sent these, so I won't go through them in great detail, which has got the urgent action from phase 3 and actually what's in our plan now. And this is just an initial gathering of what we're doing. And we are committed to doing more. So at SMT last week, they committed to actually being more radical in our transformation of health inequalities, and also the ACP. So we're looking at doing workshops at the ACP to look at actually how we can be more radical and how we can do more quickly to really reduce health inequalities in the city. So to protect the most vulnerable, the services in place to treat people with Hep B and TB, to restore NHS services inclusively, which actually Sandy already went through. And actually in terms of digital pathways, we are looking at actually piloting something in dermatology, but we are really conscious that there's a significant number of people in the city that either don't have access to equipment or don't have the skills to use it. And potentially that could be up to 120,000 people in the city without digital skills. So that has to be at the forefront of any decisions we make around a digital progression. In terms of prevention, there's lots of stuff around diabetes. And obviously we've got a big plan around flu vaccinations and actually targeting that towards vulnerable communities, particularly the BAMA community. Supporting people with mental health problems. I think you're all quite familiar with the big piece of work that's been going on during COVID. There's a physical health implementation group, and there's a big focus now on crisis care. In terms of a named board member, you'll be pleased to know that that's Brian has agreed to do that. And also Brian has agreed to a lead on a piece of work for the ACP as well, which to oversee the BAMA priorities I just mentioned. Data, there's lots of work going on in data, and also there's lots of work going on in engagement, which I briefed you all on last time, which has progressed, which is progressing well. So hand back over to Sandy.
So in terms of the next steps, we need to finalise the commission intentions, and Kate Gleave, the Deputy Director of Commissioning, is leading on that work, but ensuring that there is alignment to the phase 3 requirements. And like I said at the start of this, and feedback from the public. So we've had a lot of feedback and engagement throughout the COVID period, and continue to have. So we want to make sure that the commission intentions and the things that we are working on do match and link back to what the public are saying to us. We need to do the final national submissions, which detail how we are going to deliver those intentions over the rest of this financial year. Governing bodies development session in October will be on health inequalities, and I'm proposing to bring the full operational plan to governing body in October. And as one of the actions at the start of the meeting stated, I will be working with Lucy and her team to make sure that that is public friendly, and details what it is that we are going to do for the rest of this financial year. So we're asking a governing body for consideration, go on to the last slide, for consideration for the process that's been undertaken, the amount of work that has gone on to date in order to review, to go through the phase 3 letter, and to ensure it is aligned to the work that we're doing, the alignment of the plans across Sheffield partners, and the work that continues to happen with that. Meeting the national requirements, so those stated within the phase 3 letter, but more importantly, the implications arising from COVID within Sheffield, continuing with the long-term plan, and obviously the national planning submissions, and also the collaboration across the ICS as well. Happy to take questions.
Okay, thank you, Sandy. So I've made a note as the slides have gone down what it is governing body are being asked to consider there. Consider progress to date, how our plans align with our ACP partners, whether or not the information we've received today gives us some assurance that our commissioning intentions fit with the phase 3 requirements, the long-term plan, and that we understand the implications of COVID, and also whether this works in collaboration with our partners across the wider South Yorkshire and Bassetlaw footprint. Hand up from Mark Gamsey. I'll take some comments from Mark, please.
Yeah, thanks, Terry, and thanks, Sandy and Lucy. I just want to focus on the excuse me, on the inequalities bit. 3 things really. It's good that we've identified who our lead is. Can I just ask whether we are going to use our position to pull together a meeting of all the leads across the different NHS organisations in the city prior to our submission? Because I think that it's all very well having named leads, but we've got an interest. I mean, particularly as was mentioned by Sandy and Lucy, you know, there's a key bit there about collaboration and about an honest discussion about how we're working together. So can I just ask if that is planned? Secondly, I'm a little bit concerned about, I understand the list, the 8 bullet points, but in effect, that's what NHS England has said is what we should be doing with regard to inequalities. I do think as part of our discussions, we need to be thinking in Sheffield, is there more that we can do that isn't just set out in the NHS England expectations, some of which frankly feel a little bit odd. The please be inclusive with regard to digital, when we know by definition digital is actually quite exclusive. I'm not arguing against digital, I'm just saying let's just think through what that means. And finally, I just for clarity, I notice a new equalities group has been established. Of course, there is an inequality steering group that the CCG has sponsored for some time, and I just want to understand the relationship between that group that includes members of the VCS and governing body members, whether that group is no longer required, or whether, anyway, I just want to understand where we're going with that. So those are my 3 questions, Terry.
So over to Sandy and Lucy. I think that there's probably a bit of an answer from both of you there. I think Sandy sort of specifically around whether we are addressing the phase 3 requirements or whether we have an ambition to go further. I think the table was presented against those 8 bullet points from the phase 3 letter, but I'm just wondering if you can give us an update on the ambition beyond that, and then Lucy, if you could update us on the equality group, that would be really helpful.
Yeah, so the slides did identify those that have come from the phase 3 requirements. I think as we've stated within the presentation, tackling health inequalities has always been an objective of the organisation, and if we as an organisation feel that we need to be doing more, then certainly then that's what we need to understand what that is and work that into our plans. So I would be more than happy to have that conversation outside of the meeting. I think we've always aligned the Commission intentions and what it is that we want to deliver and achieve within a year to each of those objectives. And so what I can do is make sure, demonstrate which of those Commission intentions both match what the phase 3 requirements ask for, but also what we've spoke about in the past in terms of how we want to, as an organisation and as a place, in order to tackle health inequalities. But again, happy to work with Mark outside the meeting to bring that up to make sure it's relevant to now.
Thank you. Lucy, if we could hand over to you for the equality group clarification.
Yeah, Mark, so the group that we set up, is an equality group, and it's with people who work for the CCG who either got a particular role or they're real enthusiasts for promoting equality. And it's sort of been set up organically, and currently it doesn't sit anywhere within our structures. It's not really having much influence and it doesn't have any teeth. So we are looking at reviewing it, and Kath is leading on a review of meetings both within internally and where CCG staff attend, and one of those is the citywide health inequalities group. So we are looking at that internally, but I think the equality group, I think, and I'll talk to you about this outside, Mark, but I think it probably would feed into Speak.
Okay,
but I'm
thank
happy
you.
to talk to you to get your ideas. So I was going to talk to Speak about it on Tuesday, but we ran out of time.
Okay, so just for clarification for members of the public that are watching, Speak is our Strategic Patient Engagement, Equalities and Experience Committee, which is a formal subcommittee of our governing body and seeks that we are meeting our legal duties with requirements to equalities and experience. So Mark, are you happy to take this conversation offline to clarify further how the different groups can align? I think one of the things for me that I think would be useful is, given this group has grown organically, it does say something about how people within the CCG are trying to make equality and inequality part of their business as usual. And I think whatever we do in terms of group alignment, we need to sort of try and keep that that spirit and alive and kicking in absolutely everything we do, so that it isn't a secondary consideration on top of a commissioning plan, but it runs right through it. So back over to you, Mark.
Yeah, thanks, Terry. That's helpful. I'm still the Inequalities Steering Group and the Equalities Group, I still don't know whether we're talking about the same thing or two separate groups, but we can sort that out after. I think one of the lessons, and indeed Speak is a good example of that, is I think it's an indication of when an organisation really starts to take an issue seriously as it starts to formalise it. And I think Speak, which started off as an informal group and then moved to a sort of constitutional status, has really helped. And maybe that's one of the things that we need to be thinking about going forward with regard to inequalities. I'm assuming that, I see Brian's got his hand up, I'm assuming he'll pick up on the other point, which is about convening a meeting that I made with regard to convening a meeting of other inequalities leads across the NHS family. I suspect Brian's keen to go on that.
I am keen to respond to that, Mark, because the hour before governing body, we met with those nominated leads. So that group already exists. They know what we're doing. They know what our activity is. Everybody is aligned to those immediate priorities and to add to what Sandy said as well. That is the immediate priorities. That's the start. That's not the end. So it's almost let's have an initial focus on those. But the ambition and the desire of everybody that sits on that group is to go deeper, much deeper. And as you say, make it the mainstream of what we do, not an add-on. And I'm pleased to be able to represent both this organisation in that group and also take the lead alongside Clive Clark across the ACP, the Accountable Care Partnership, and all our organisations. It's also worth noting as well that Clive has now secured a role regionally as Director of Inclusion. So he is going to spend most of his time working in a regional capacity, but we have him a half a day a week working alongside me and within our organisation and across our organisations to embed this in the way we do business. So personally, quite excited about the scale of the challenge that lies in this, but the enthusiasm that people are coming to it. And for me, experience and speak for the first time on Monday and being able to identify how we make those connections of equality and inequality across everything that we do.
Okay, so I'll allow you to come back on this one, Mark, and then we'll move on to some some other reflections.
Indeed, thank you, Chair. Just a very quick question is, when we meet again to look at what we're going to be doing around inequalities, as I think Sandy said, in a month or so's time, I'm assuming that what we will be feeding back up the ladder to NHS England is a picture from across all NHS organisations, not just what we're doing.
And Brian's nodding away there. So
yes, Mark, absolutely. So at the minute, it could look a bit CCG heavy, but what we are doing is building that plan and getting sort of the depth across all our organisations for a final submission. And Jane Jennifer is supporting us from the Accountable Care Partnership in that work as well, alongside our partners. It's an open door that we're banging on.
Okay, thank you, Brian. So just to add to that, Mark, in terms of, is this coming from the CCG, or is this more of a broad thought? Unfortunately, Greg's had to leave the call at 3 o'clock. But certainly these are discussions that we've been picking up in our Sheffield Health and Wellbeing Board. And certainly, having looked through the commissioning intentions presentation, I feel assured that our intentions support our system-wide view in Sheffield in terms of how we seek to address health inequality. And certainly our commissioning intentions always have to go back to the Health and Wellbeing Board to be signed off. So hopefully that collective view of it will be noted. And certainly looking at the ACP work stream plans, things seem to be joining up nicely and heading in the same direction. Okay, Judy, please.
I noticed that BAME needs and inequalities are mentioned specifically, and I think that's absolutely right. I would want to ask about disability and learning disability, because the impact on disabled people of COVID has been noticeable, but that doesn't seem to me to be referenced specifically. So can I ask about where that is, or what intentions are around those two disabilities?
So Lucy, are you able to answer that in your role as the Equalities Lead?
Yeah, so we have focused initially on the BAME community, and that's where we've made sort of good progress, but we've gone through the plan, and we've gone through all the intelligence we've had, and we've identified any gaps with the work that we're doing. So we're going through by protected characteristic and also looking at poverty and deprivation as well. And we realise that one of our biggest gaps is people with disability. So there's lots of work going on, but it just wasn't in the slides today. But yeah, we're doing lots of work going through who are most disadvantaged and who have the greatest health inequalities.
Sandy, did you want to come in on that?
Yes, I just wanted to say that learning disability very much features in the requirements of restoring the services and the what you'll find next month in the operational plan is the indicators and the pieces of work that we have to achieve and deliver. And there are a number of things that specifically relate to those with learning disabilities and mental health. So those particular areas are heavily focused on in terms of making sure we have the right provision in place for post-COVID as well as moving forwards, but there are specifics that the requirements actually ask us to make sure we deliver on as well.
Okay, thank you. Nikki Bates, please.
Hi, thanks. Thanks for all this work. It's great to look at all the things that we've got in mind. One thing that I noted was about the all-age mental health pathways, which are very welcome. Are there any other plans for any all-age pathways, particularly within community services? We think about things particularly like dermatology or ENT, and any integration of services in this way will help with transition.
So if I just come in on that, so the transition across from children's to adults is very much one of our commissioning intentions, which I've put in the detail of the slides. There's the specifics around that and the specific pathways, again, will be detailed within the operational plan that goes into specifics. But I'm more than happy to pick this up outside the meeting, Nikki, with you to go through what that looks like and to see if there's anything that you can comment on and help us with prior to us finalising them.
Thank you.
Lee Sorsby, please.
Hi, thanks, Terry. I'm Lee Sorsby, I'm a GP in Sheffield. Absolutely welcoming this emphasis on health inequalities and addressing them and hopefully addressing the factors which underpin them and perpetuate them. I really recognise what you say about it always being part of our organisational approach, but history tells us that actually over the last few years we've not actually made much headway at all. And I feel that this is a bit different, and we're wanting to, not just pay lip service to it and really start to tackle the really complex and multifactorial reasons why health inequalities exist. Just to flag up what Mark was saying, really, the Health Inequality Steering Group has existed for a number of years now and never once has been consulted. and within that group, there are a lot of people with a huge amount of expertise. So we would be more than willing to work alongside whatever groups are being formed. Just to add, there's a lot of evidence behind health inequalities and what perpetuates them, and there's an increasingly overwhelming body of evidence around adverse childhood events and trauma and the impact that has on perpetuating health inequalities. I've just recently been looking at the work that NHS Scotland and NHS Wales are doing in this area. They are streets ahead of NHS England in this, and so I've been talking with Debbie Hanson from the council about what we could do from a Sheffield point of view in terms of weaving this work through all the work that we do in terms of our commissioning. So we're just starting some discussions there, which again I'm more than happy to discuss outside this meeting. So really it's just to flag up those areas of expertise that we've got and the evidence that we've got. There are a lot of really positive things that can be done to make a difference, but it does have to be woven through all of our commissioning intentions, and within health and within education and employment and housing and all the rest, it all joins together. So I welcome this sort of increased profile of the problem, but also discussions around working together. I'm very, very happy to feed in with the bit that I know as well.
Thank you, Lee. I'm sure that offer will be very welcome. Any further comments from governing body members? No. So hopefully, Sandy, that's given you some rigour to some of the plans, so you can fine-tune those and bring those back to governing body in October for discussion at the development session of our operational plan. I think going back through it, I think there have been some concerns about which groups are being concerned, but largely what I've heard today is governing body are happy with the process of where we've got. I think there is a clear alignment with our broader ACP plans and also the health and well-being strategy for the city. Very clearly, there was a list of actions against the phase 3 requirements, but we have identified that we do wish to go a bit further and be a bit bolder as a CCG. And you've also highlighted the parts where we will collaborate with our partners in South Yorkshire and Bassetlaw. So are you both sufficiently happy the governing body today has answered the questions that you've brought to us?
Yes, thank you, Chair. Appreciate everyone's feedback.
Okay, thank you. So I will now move us on to the next part of the agenda, which is the month 4 finance report. You will have received that as item C in the paper pack, and I'll hand over to Jackie Mills.
Thank you, Terry. So I'm Jackie Mills, I'm Director of Finance at CCG. So this report is for the period up to the end of July. Governing body members will recall that unlike previous years, we've moved into a revised financial framework for the NHS. And initially the CCG was only allocated 4 months worth of allocation. So this report reports the position for that initial period. So the good news, compared to why I informed you last month, is that we've now received increased allocations for months 1 to 3 for the additional expenditure we've incurred, both as a result of COVID and over and above the indicative allocation that was originally notified to us. So the financial risk and the financial variances that I highlighted in the previous report have reduced. However, because we haven't yet, we hadn't at the time of writing had confirmation of the month 4 additional allocations, there was still a reported overspend of £5.1 million. That broke down between 2.9 million of COVID spend on various initiatives in responding to the pandemic and 2.2 million non-COVID variants. The NHS England and Improvement have confirmed that the interim financial arrangements where we receive retrospective top-ups based on our spend will continue through August and September, but we anticipate that from October onwards there will be a new financial regime in place. The challenge is that whilst we are now in the start of September, so less than 1 month till the interim arrangements cease, we still haven't had confirmation of the likely funding that's due to come into the ICS and so flowing to different organisations within the ICS. It is fairly challenging because Sandy's just described a planning return that is required to show lots of assumptions around activity and workforce, and yet we don't know what funding we will have coming into the system to be able to support that. And it is a fairly unique year. In all of the years that I've experienced, we do that planning in tandem, financial activity and workforce. It remains a challenging position to understand both the current financial position, but also the scope that we will have in the latter parts of the month, both to deliver a balanced financial position, but also to make progress on a number of areas we've just discussed as part of the commissioning intentions. So I think they were the main things I just wanted to draw out from the report, a level of uncertainty and risk that remains, but some good news in terms of having had some additional allocations confirmed. So I'm happy to take any questions.
Thank you, Jackie. So Lee Salisbury, please.
Thanks as ever, Jackie, for this. I think you and your team are amazing, managing to stay sane while you're trying to sort out these all these uncertainties and the pressure that I'm sure is involved with that. The report was really useful and really well written, so thank you for that. I'm really sorry, my battery's about to run low. Hang on. I'm one of the people who would be disadvantaged by too much IT being involved in my care, I think. Okay, I'm back on. Sorry about that. It was really just a minuscule sort of point of clarity really in Appendix A. I wasn't quite clear why there seemed to be no mental health IFRs agreed or paid for, there's just zero expenditure on there. And it's just to work out, is that because there were no referrals for IFR under mental health, or is that because the service has just been put on hold during COVID? So it's just to get a bit of understanding about that. And then there was one other question about this too.
Okay, so for IFR spend that we would normally have with NHS providers, that will be included within their block allocations now, and so we can't break down those block spends between the areas that we've previously been able to do. So for NHS organisations, they're just included in the acute blocks. For smaller NHS contracts or non-NHS contracts. So for the smaller NHS contracts, we don't pay anything to any organisation that's traditionally has funding less than 250,000. So they're expected to just get paid that through any retrospective top-ups that they are claiming. So that's again a nuance of the interim financial arrangements. In terms of, I am surprised there isn't any independent sector IFR spend, but a lot of that goes through our arrangements with the Care Trust, where they manage out-of-town placements on our behalf. So I suspect that the spend will be going through their books, not ours.
Okay, thank you. And the only other question again,
Lee, because that is off the top of my head, so I will just double check that that's the correct explanation, but that's what I would expect.
That's fine, thank you. There was just one other question on the same appendix as well. Again, just looking under primary care other services, there seems to be a big underspend there, 387.9% less than normal. And I was just to understand really what that refers to. Not that I expect you to know everything off the top of your head, Jackie. But...
I will get back to you on that one. I can't okay. Off the top of my head. I'm sure there's a very clear rationale.
Okay, thank you.
Okay, thank you for those very eagle-eyed observations there, Lee. You've obviously gone into quite some detail with the budget, and I think they are important points that you've raised there. Do any other members of governing body wish to raise any questions or points on the financial position? Brian.
Thank you, Jackie, and thank you for the paper. And I know we eat, sleep and breathe this. You have made a very unique, complex scenario that we're living in, quite simple in terms of trying to explain something that's very complex. I just want to sort of make governing body aware that the final bullet point on the impact of the new financial arrangements for the period October to March, we still don't know that. And there is quite a significant risk in that, which links back to, as you've outlined, Jackie, Sandy's presentation around the planning and what we are able to do and the impact of not being able to do as much as may be expected, and the almost the penalty that could potentially be applied to us as a system, both here in Sheffield and across South Yorkshire and Bassetlaw. So if ever there was a world of shifting sands, this regime, whatever the regime will be from October to March, we will need as a governing body to be very aware and sighted of the implications and consequences of what those outcomes may be, both of the regime and then the impact of that regime on what we do for the next 5 months now.
Okay, thank you, Brian. I think that's a very relevant point, that we can have our ambitions, but without the clarity over finance at this stage, there is a risk looming on the horizon that we may not be able to realise each of those ambitions individually. Hopefully we will get some greater clarity on that over the coming weeks as we move forward. Mandy Forrest, so just before we bring you in, Mandy, just to highlight, this was the item that you declared a conflict of interest in.
Yes, yeah, just very quickly, and it's a very minor point, so apologies for it, but in table 3, under COVID expenditure, the hospital discharge programme, it says that the Carer Centre, of which I'm the chair, got some money. Just to clarify, and I've checked this out with finance, we have had hospital discharge programme money in the past, but not in the COVID period. Our project ended in January. We were one of 4 organisations providing that support, but we did have a tiny bit of money to support carers of people with dementia. We had £4,000 in the COVID period, but I think that was a different pot of money. But I just wanted to make two points really leading on from Brian. It's really frustrating to know that in less than a month's time we'll have a new financial regime and we don't know what it is. It's not the only issue the CCG faces where we don't have clear guidance from the centre or government or whoever. It'll come up later in the agenda around continuing healthcare, around changing guidance, and it's just very annoying. Well, that's one word for it. To be working in a context where it really isn't clear, where we don't have time to properly plan and properly put things in place. This is no way to run a system, and it's very unfair locally that the penalties all seem to come down to a local level. And as a layperson, I remain baffled that we were told at the beginning of the pandemic that, you know, whatever it costs to sort this out in the NHS, it'll be fine. Whereas 6 months on, it seems to me, as a layperson, there's all sorts of smoke and mirrors going on to cover those costs. And I just really worry that our ambitions are going to be put on hold because the money we might have had has had to go into the COVID pandemic only. And that seems to have completely skewed our agenda.
Okay, thank you for those reflections, Mandy. On the point, Jackie, with regards to those specific lines in the spreadsheet, I wonder if you'll be able to come back to us on that.
That's fine. And just picking up on Mandy's last point, so I recognise and share the frustration. I just want to give some assurance that we are preparing in terms of whatever comes, that we can respond quickly and understand the implications of that. So it's challenging, but we are trying to make sure that we're putting all our efforts into being able to quickly understand that once information is available. I think also to note that we are working very closely with partners to understand how we do this better between us, so that we're not retreating into just protecting individual organisations' financial position. So in some ways, the frustration drives a commonality of requirements, which is probably not unhelpful. So we'll try and make the most as ever of the difficulties that we face to maximise what we can get out of it. But yeah, recognising it's not at all satisfactory, but we'll rise to the challenge, I'm sure. And we're also trying to make sure that where there are absolutely things we need to make progress on, even in the absence, we need to have a level of risk appetite to be able to make some decisions, so we're not paralysed by all of this. So it's important that we make you aware of what those issues are and the risks that we might be taking, but it's not to say that we shouldn't be trying to make progress on those areas.
Okay, thank you, Jackie. Are there any further comments or questions for Jackie on this item? Okay, thank you, Jackie and finance team for the thorough and as Brian reflected, uncomplicated way in which you had managed to present some very complex information. So on to item 10, paper D, which is our performance and delivery report. I'm going to hand over to Kath Tilney, our Associate Director of Corporate Services.
Thank you, Chair. So yes, the purpose of the report, which you've been receiving regularly, is about updating governing body on a number of performance and assurance areas. So in this report, included in this, we've got the key performance measures regarding our providers. We've got some organisational performance with regard to our staff. And on top of that, sharing the views and experience of our staff. And then some statistics related to COVID-19 and around how the local situation is planning for winter as well to expand the flu vaccination programme. So I'm assuming you've all had a chance to read the report. So what I was going to do was just highlight 3 areas to you, those being COVID impact on services, the COVID impact on our CCG staff, and then something around this report and where it can go in the future. So in relation to the COVID impact on services, Sandy talked earlier a lot around the phase 3 requirements, and I think Brian mentioned last time at the last meeting as well, around the clearing the elective backlog is one of the key requirements, and the challenges associated with that that are making this difficult. So one of the key measures that links to this is the growing number of 52-week waits that we're seeing, and our 2 local providers currently have 44 Sheffield patients that have been waiting for over 52 weeks for their elective treatment. Previously, this is something we've just not seen in Sheffield, and with our local providers, we've just not had this issue. It has been a big issue in other areas, but not in Sheffield. These waits are mainly linked to people waiting for diagnostics or inpatient treatment. The good news associated with this is around outpatient activity, because the providers are very much on top of that because they've been able to use phone and video appointments. So the outpatient waits are actually down and the backlog has been cleared a bit. We currently have got limited information about how we compare to other areas, because that reporting isn't flowing in the same way as it has done previously. As soon as that's available, that's something that we want to include in this so that we can see. It sounds horrendous having 44 Sheffield waiters, and it is. I'm not sure what's happening in the other areas, so I think it's worth us just having that, having a fuller picture and understanding that. As far as the COVID impact on staff, that comes up in a few different areas in the report. We're seeing that staff sickness is down quite significantly in Q1, and all 3 months in Q1 we're below 3%, and we've not been at that level. I don't, in the report you can see we've not certainly weren't at that level last year. I haven't seen the previous years, but and it was up at 4.9% in March, so it's a real big drop. And I think I've heard various theories as to why that is the case, and there's something around there being lower transmission of illness, and also potentially people not needing to come into the office might mean that they can work more flexibly. So we need to understand that a bit better and keep an eye on it. But it's a good thing. We've also, Brian introduced the staff temperature check at the last governing body meeting. This is a fortnightly survey. It's a quick survey that we ask staff to complete to let us know how they're coping during these times with working at home and how we can support them more effectively. And we're really grateful for the staff that have been contributing to that and sharing their concerns or what their suggestions are for improvement. The report is highlighted, there's quite different experience of staff. Some are really finding this useful, helpful, and it's helping them with work-life balance and not having to commute. Others are finding it quite difficult, and there's quite a lot of concerns amongst staff that we wanted to make sure that we can address. And alongside that, we've started a feedback loop going. So there's a group of staff that are looking at what's coming out of the temperature check and feeding back on that in our fortnightly team briefing sessions. And we've called that our thoughts, our actions. And within the report, there's a couple of examples of what's happening there. But this feels like this is a growing area and feels really positive step for the organisation, because we're having real sort of open discussions, live discussions about what's concerning staff. So that will develop over time. Then finally, around future reports, as Sandy was talking earlier about the phase 3 implementation framework, and then anything that we want to do on top of that we agree would be included. this report will include the reporting against that. So we'll make sure that we've got that feedback loop for governing body. And as I said earlier, benchmarking information, if we can bring some of that in, that feels like that would be helpful to me. So I'd welcome your views on that, and any other suggestions or comments you've got about this report, I would welcome either now or at any time in the future. So happy to take your questions on that.
Okay, thank you, Kath. So does anybody have any questions or comments? So Nikki Bates, please.
Hi, yeah, the staff temperature check I think is really interesting, and it would be perhaps an idea to get governing bodies ideas about how they feel about not seeing each other and not going into 722. I feel personally quite separated from my colleagues, and I've always valued the informal chats and conversations that we have. So we don't get asked as governing body GPs. I know there are the execs will be included in the temperature check, I suspect, but we as governing body GPs, we don't get asked about our opinions. So perhaps we should share those.
Okay, thank you.
Yeah, I don't think there's any reason why we couldn't expand.
So the link to the staff temperature check, a pop-up occurs on CCG staff Windows machines, but there is a direct link to that temperature check through our intranet page. I'm just wondering, Lucy, is it something the comms team could pick up to include governing body members in asking them to fill that survey in, please?
Yeah, it's only a SurveyMonkey link, so we can easily send it around.
Okay,
Thank
great.
you.
And that will get those opinions in. So thank you for raising that, Nikki. Lisa Phillip, please.
Okay. I don't have a question, Kath. It's just a comment really about the staff temperature check, and I feel it's a great idea and it's a great opportunity for people to share their stories and concerns and things. And I particularly like that you have the feedback loop, because sometimes we give our opinions and we don't get anything back. So the fact that you're doing that every 2 weeks is fantastic. And I think this kind of model kind of gives an opportunity for bottom-up working. When you're shaping the way that we're going to work, well, post-COVID. I say post-COVID, but just going forward. So I just wanted to say well done.
Thank you.
Okay, thank you for that comment, Lisa. I've got a point to bring back on that a little bit later and ask of governing bodies. So I agree, and very much the setup of our thoughts and our actions was to move away from a top-heavy leadership structure where individual members of staff were dependent on a line manager to make a decision or to change something within the CCG, and very much about making sure that staff felt empowered to be able to make the changes in their work life that made things better for them. So very much this is part of our staff being able to demonstrate that. Now, one of the things we have asked, there is also a COVID learning group where groups of staff are coming together to begin to unpick and understand some of the challenges they had during COVID and how they overcame those challenges. And part of that is forming a community of practice. And members of the group have been invited to come and present this to governing body. However, it still feels a little bit like we've got individual teams and individual members of staff coming to a senior group of people to tell a story and to ask something. So the ask of the governing body is whether members of governing body would be willing to do that in reverse. So part of it is to go to the learning group to tell your story and almost to work in a reverse mentor fashion so that you could begin to understand those problems on the ground and support people in making changes in the organisation, as opposed to people making an ask of a senior team. So I very, very much welcome input from members of governing body, and hopefully we can pick that up outside of today's meeting. Amir, please.
Yeah, thank you for that, Kath. On your last point, Terry, I'd be quite happy to come and give our experience that we had of remote working at this practice. I'm sorry if you've already said this, Kath. I seem to be having internet problems, so I keep coming in and out. Hopefully you can hear me. A really basic question, really. I've often sat here and listened to these figures about weights and 52-week weights and etc. And we seem to be rather hung up on that. But is that then dissected down into good clinical medicine, good clinical practice of what the weights are? You know, the obvious being, is it toenails or is it heart surgery?
Yes, yes, it is. There's a lot more detail under that, and there's a lot of work going on at the moment, and that partly has been steered nationally as to the priority of those people that are waiting. So it isn't necessarily the longer waiters. If they're lower priority, they wouldn't necessarily sort of hit first. That it's being managed as to patient needs. So that there's lots of different sort of elements that underneath that.
Okay. Would it be more useful, given the current crisis, for want of a better word, to actually be able to see the more serious stuff, not waiting so long, or having an idea of how long the more serious stuff is waiting for? Again, you know, I appreciate this thing about cancers, which is quite national, but if there's 44 people in Sheffield waiting longer than 52 weeks, it would be useful to know for what kind of conditions.
So, Kath, would you be able to bring that information back outside of the meeting? I'll just add one thing in there, Amir, as part of the phase 3 planning. In terms of reducing the number of people that are breaching those waiting standards, there has been a specific ask that it isn't just dealing with the people in order of where they are in the queue, but very much it needs to be based on clinical priority, consequence of not treating sooner, and also the health inequality factors that those individuals who are waiting have. So there's quite a complex way in which those lists need to be worked at. And I'm wondering whether it will be helpful for you and Kath to pick that up outside so that we can understand the detail of that.
We'll look into the information that we've got that can help explain that.
Thank you.
Thanks. Brian, please.
Thank you, Chair. And I better introduce myself, saying that we're nearly at the end of the meeting. So I'm Brian Hughes, Deputy Accountable Officer. Apologies for not introducing myself earlier, but hopefully everybody knows me by now. I just wanted to sort of continue with the temperature check conversation, and the fact that, Lisa, you explained, or you sort of outlined the circumstances that we're working in are quite weird and very different. I think it's really important that we're reaching out to staff on a fortnightly basis. A staff brief is hopefully a dynamic and an active space where people don't have to join. But, you know, I think the lowest attendance that we had in the midst of holidays was about 130, 140. So staff want to hear and want to get engaged in it, even in this virtual world. And the bit that I want to just sort of almost extend and continue to extend the invite into governing body is, I know it's difficult because everybody's busy, but it is really nice to see and hear governing body representation at the staff briefings as well. It tends to be a bit of either a double or a triple act between Terry, myself and Leslie, but increasingly, and I think as people get more used to it, and the last one was a bit of a social experiment because we recorded the conversation, and that's so that people who weren't able to join live could at least hear the messages after it. But as I experience and go through it, it is much broader than just Terry, myself, or Leslie speaking. It is very much, as staff briefs should be, about that engagement. What are we proud of? What are we working on, particularly with teams, and particularly where the work is coming back into those areas that people have used to work and are now coming back into those work streams as well. So it's an open invite and almost an encouragement where people can, and I know, Mandy, you join sort of regularly with us, but if colleagues are able to join, it's really powerful and it sends a strong message across our organisation as well. So thank you.
Thank you, Brian. Mandy Forrest, please.
I do want to ask something, but I think Chris has had a hand up for ages.
I'm taking people in order. Their hands went up. I've got an order. You were first, I'm afraid.
Oh, right. Sorry, Chris.
Right. Sorry.
I just wanted to ask Kath a couple of things on page 3 and 4 of your report. So the bit about the local outbreak board managing future outbreaks, I just wondered how much local autonomy we will have, having seen some of the stuff that's gone on in Greater Manchester this week, where there's been a disagreement between the Department of Health and Social Care and the local council. So do we know how that would play out? And then the bit below that on the flu vaccination programme, which I absolutely understand is completely complex and enormous, but you talk about the phasing of it. Do we have a sense of the timescale yet? And I just wondered, maybe at some point at a future meeting we could have a longer piece about that. Thank you.
I'm going to ask my colleagues whether they can answer.
Yeah. So unfortunately, Greg has dropped off the call, and the local outbreak plans, as you've rightly pointed out, Mandy, are part of the local authority response. And CCG has representation on that, along with lots of other partners in the city. I think you quite rightly point out there is a tension between local outbreak planning and national control. And I'm just wondering whether for our development session in October, whether it would be helpful for Greg Fell to come and give us an update on that, so that we can get a bit more detail on that. And likewise with the second point around flu planning, there's still some uncertainty over national guidance, particularly MRHA, and I'm wondering whether Brian or Zach might be able to give us an update on flu in October, if that's okay.
Yeah, I think Zach, if he's on, may be able to update briefly on the outbreak board. If you want to do that now, or we can sort of leave that to October.
I just wonder whether because it's quite detailed, whether it would be better for us to bring that in October. I'm obviously being mindful that our next session starts in 14 minutes. And
I'm on, but no picture. But I think that probably makes sense, Terry, just to have a bit more time to go through it. I think it's quite complicated. I think basically nationally the law is set, but locally there may be flexibility in how some of the laws are implemented. So it might be quite an interesting one to spend a bit more time on.
Thank you, Zach. Okay, Lee Sorsby, please.
Sorry, I was just, while you were talking, I was trying to find how to put my hand down, because I was going to ask, just mention about the flu, because I think we do need to talk about it at governing body. As you know, there's been a lot of activity and work regarding it. I suppose just alongside that, though, is how we as an organisation will be managing public expectations, because obviously they are very high. A huge cohort of people have been told they should have a flu vaccine, and we're not certain, A, whether the vaccines will be available, and B, how they're going to be administered. And I just feel our communications need to be on the front foot with this one. So yeah, that was it. Thanks.
Okay, thank you, Lee. Finally, Chris. You've been waiting so patiently.
That's okay. In fact, some of the things have been said, so I'll be brief, but I particularly wanted to talk about the temperature check, and I'm part of the COVID learning group and how important that's been for us. And it's really developed further on from the improvement plan group. So a lot of those issues to do with staff, we wanted to make sure we were checking and getting feedback and carrying on with the progress we were making. I was going to mention, Brian, the staff briefing, because I do think that sets the whole culture of how we want to engage staff and how much it's been valued. And on top of that, we've had the speaker sessions, Black and minority ethnic groups, which again have been really, well, I'm sure for everybody, but for me to hear that staff experience and have some thoughts about, you know, what does that mean for our learning going forward. And I just also wanted to mention the staff forum, because they've really engaged in this. And it's really tricky with the COVID situation because there's work and there's general, and we try and pick those up, and the situation does change, and we are trying to do more in terms of feeding back about what's happened. So I just wanted to recognise that work, and Kath and Sandy and Sarah have done a lot of work with regard to that. Thanks.
Okay, thank you, Chris. So thank you, Kath, for presenting that paper. First time doing that at a governing body. So thank you for pulling out the 3 key areas for us to focus on. So just a few add-on parts to Kath's paper, sort of with regards to our response as a governing body. The first one is around organisational culture, and that's something that comes through quite strongly in the temperature check. It's just to remind members of governing body who haven't had the opportunity to attend the culture change programme. Those of you that have been on it have found it a really positive experience. So if you've not been on the culture change programme, there are 3 more dates available, and we'll get those sent out to governing body, and absolutely please do book onto those. It's well worth spending your time on it. The second one is part of pre-COVID times. I regularly held a chair's surgery for members of staff to drop in, and there's been an ask of whether other members of the governing body would be willing to do that on a ad hoc rotational basis to keep in contact with staff. So again, you know, if it's something you're willing to do, please drop me an email afterwards. And then finally, just to remind members of governing body about the request for reverse mentoring into the COVID learning group. If it's something that you would be willing to do, we would very much like to hear from you on that one. So on to the final big item for today's agenda, which is the Patient Safety, Quality and Experience Report. Over to Alan Windle, please.
Thank you, Chair. So I'll start with continuing healthcare. As the CCG was informed last month and was in the governing body papers, the recommencement of CHC activity within relation to decision supports tools commenced on the 1st of September. So that links back to the national framework. However, we've got to remember as governing body, there is 3 cohorts to this group. So it does link back to the earlier question of our communication. So the original group, which was pre-March this year, we have a significant number of individuals who require a full DST that are currently funded by the CCG or part funded by the CCG. And you've seen in previous governing body reports that there was delayed assessments there of around 58%. So there's a plan and a communication plan for those individuals, because we've linked with those throughout the COVID period, just to ensure that the packages of cares are still meeting the needs. Then there's a group that what I would suggest is the kind of the COVID period from March until September, which this group of individuals on discharge from hospital or preventing admission to hospital required packages of care and were funded in a central pot. Those group from the 1st of September will be continued to be funded centrally. That we will be able to draw money back. I hope I'm using the right words, the Director of Finance there. It's not an indeterminate time. The working time period that we have to complete these assessments by is 31st of March 2021. However, I do feel as a CCG will be asked to complete far sooner than that point. And we will be reporting back to NHS England an improvement on the figures of meeting that group. And then there's the third group. So there's new assessments now from the 1st of September. 2 bits of guidance lead on these. One is the discharge process. where individuals being discharged who require assessment or package of care or may need one will be funded again from a central pot, but for a period of 6 weeks. 6 weeks will determine the both health and social care to undertake assessments. So even, I'm not just talking about CHC here, it is social care as well. And we'll have a time limited response in order to undertake those assessments. If we get to the end of that 6 week period and an assessment isn't completed, then the authority that is lacking an assessment will take the responsibility of funding that continued package of care until an assessment completes. So communications between the 3 different groups of wherever they sit in the community, whether that be in nursing, residential, whether it be in their own homes, have continued and will continue to go ahead. So we've communicated with the initial group through the whole period. The second group, the COVID period, have been contacted and made aware that an assessment will be needed to take place within this period. And the third group, as the 1st of September, we've got joint communications with the local authority where people will be informed of this period of funding until an assessment takes place. So pretty complex. There still continues to be emerging guidance that we require within relation to fast track assessments. That still hasn't been delivered so far. And currently all that activity has to be undertaken with the current workforce resource that we have, both from a health and social care. So there's going to be quite a lot of pull on both health and social care's workforce to achieve these 3 different work streams. So again, continued awaiting guidance within relation to fast tracks, and also there is a potential, it is being talked, but we haven't had specific direction, that there may be some financial support that CCGs will be able to utilise for the continuing healthcare process, but that is not confirmed yet as such. So we're awaiting that. But I just wanted to assure governing body within we've also had a director level meeting within the past week between the CCG and social care, the local authority, in order to work through some of the challenges that we face together. And I think I can give assurance to governing body that that was a really effective discussion and some working groups to take some of the challenges that we face together forward. On other matters in continuing healthcare, patient safety, additional, we've talked about the phase 3 approach. In addition to what's already been described, all NHS providers as of November will have to have an all-time equivalent patient safety expert. This is a new role. It's part of the patient safety developments and strategy that came out in June. Again, CCGs weren't anticipating to have the same level as a provider organisation, but it's pretty clear that we do need to. So we're currently working through how that looks like for the CCG, and probably within the next, by the next public governing body, we'll probably will have a plan in place for how we will deliver that. I wanted to note to governing body, the 17th of September is World Patient Safety Day. And we're working with communications because it's centering around health sector safety, and quite pertinent with the COVID period. So watch this space. We'll be putting some communications out and doing some work on that. Safeguarding as the COVID period, and governing body has been aware that the safeguarding team have been supporting primary care on assessments. That ceased on the 1st of September. That period is now concluded, or there's a bit of mopping up work that we're currently doing there. However, I wanted to again reassure governing body within relation to our duties on safeguarding. you know, we're still here as a resource for primary care and all providers within relation to safeguarding and assurance. Infection control, in a similar position. Infection control, our team obviously supported the gold, silver and command structures in CCGs and wider across the Sheffield city. They are returning to while continuing to support COVID outbreaks. So any outbreaks in the city are supporting public health and messages in order to address outbreak management. But while they continue to now to pick up further work within relation to MRSA breakouts also. Leader, which is learning from deaths. This is a new part of the report coming through. We have a duty, again, to complete all leader assessments or learning from death in learning disabilities by December this year. We are on a good pathway. We're halfway through. We've got significant assurance that we will meet that deadline. There was a risk within relation to, again, workforce resource. However, just prior to governing body, I have got a message from the ICS team that we'll be able to allocate some money to continue that resource to achieve our deadline of December. We're already halfway through. Half of the cohort of 40 completed and requiring to go through a quality assurance process. But the main aim for this, for me, it's back to the planning discussion that we had earlier. In learning from deaths, there'll be key points for us to pick up on planning for the future, particularly within learning disabilities. So an annual report on the past 12 months of Leader will be out shortly. So, and that will be going through our Quality Assurance Committee. And finally, as a key point, the Care Trust, Sheffield Health and Social Care Trust. I've previously reported to governing body that we have a group that is, we're calling a lot of things COVID groups, but it was a COVID management group of locally that was set up to oversee the both the CQC regulatory letters and outcomes and oversee the Back to Good programme. Interestingly, that has ceased. It's moved to what would normally be a strategic group, and we've had the first meeting of that strategic group. I can feed back to governing body that on the whole there was a good praise really from all partners across the NHS England and Improvement and the CCG on the urgent actions that are being required by the Trust and moving forward. So that there is particularly some good work in that area. Again, I suppose the Trust themselves recognising and ourselves supporting is the sustainability of continued improvement, which we're working through, and it appears to be, again, very favourable. And I think that is the end. Thank you very much, Chair. Happy to take any questions.
Thanks, Alan. So questions from Mandy, please.
Thanks. It's not so much a question as a statement, really. We agreed at Quality Assurance Committee last week. There were 2 or 3 things that we wanted to bring governing body's attention to, and Alan has covered them, but continuing healthcare was an issue of concern at Quality Assurance Committee. The team have mobilised themselves to deliver whatever needs to be delivered, but when we met last week, it wasn't entirely clear what was required by what timescales, and the pressure on the team will be huge. And it's a particular worry because CHC is such a contentious issue and absolutely stressful for families going through it. It's the difference between whether you pay for care or don't pay for care. And so if it's not clear, there's all sorts of risks we face as an organisation, as a system, financial risks, but also reputational risks, not of our making. So we need to keep our eye on this and absolutely make sure that we communicate clearly with families in as much as we're able to. The other issue we had a long discussion about was the support care homes have had throughout the pandemic, and the fantastic work that has been done by the team. Long before any guidance came out, we were doing it. And as much as we've been able to, supporting care homes, there are issues and there are continuing risks. And we talked about testing in care homes and where that's up to and the availability for tests. So some of the guidance has, the national guidance hasn't yet been fully implemented across the country. So I'm sorry I keep on saying national things that haven't quite worked. I'm not meaning to be wholly negative, but we said we would report these risks and concerns to governing body. Thank you.
Thank you, Mandy. Alan, I think there's things that can be reflected back if possible. Okay, any further comments or questions there on this report? No. Okay, I'll move us on then to the final part of today's agenda. So the part 3 was largely around oral updates from the chair and from the accountable officer, with a particular shine on the ACP and our intentions and the work that we're doing. I think most of what I wanted to say has very much been covered by the discussions this afternoon, and bearing in mind that we have another session to go to, I won't give a verbal update on those things because I think they have pretty much been covered. So I'll move us then on to the reports circulated in advance for noting on item 15 of the agenda. Does anybody have any comments that they wish to raise about either of those papers? No. Okay. So I will bring the meeting to a close, as I've not been notified of any items of other business ahead of the meeting. The next governing body meeting will possibly be a short meeting on Thursday, the 1st of October at 1 p.m. But that will be notified via our website and via email to governing body members in due course. The second thing to mention is that on the 1st of October will be the CCG annual public meeting, which will be hosted online. Our plan is to hold that in the morning at around 10 a.m. and details of that will be posted on the CCG website. Members of governing body who are able to attend would be more than welcome. It will involve some interactive questions with members of the public, and also the communications team are compiling a video of some of our key achievements and challenges over the past 12 months so that we can share that online. Jackie, your hand went up briefly there, and I think you were going to introduce that. Is there anything extra you want to add to that? No. Okay. So that brings the meeting this afternoon to a close. Thank you very much for members of the public for joining us. Lucy, could you stop the recording?